Welcome back to the deep dive. Today, we're really laying the groundwork, I think, for your entire pediatric practice.
Absolutely.
We are digging into Chapter 1 of Essentials of Pediatric Nursing, pulling out that core framework you absolutely need. We're talking about the concepts that, well, they really underpin safe, effective care for every single child.
Yeah, this is foundational stuff. Whether you're just heading into clinicals or maybe studying for your boards, this is critical. We're going to cement three main things today.
Okay.
First, how we actually define and measure child health now. Second, the philosophy that really guides modern pediatric nursing.
Right.
And third, those critical ethical and legal boundaries, stuff you'll navigate every day, especially around consent and confidentiality.
So our goal here is to really distill these ideas.
Yeah.
We want to establish firmly that kids aren't just miniature adults.
Exactly.
They're unique, their health is measured differently, their care follows specific ethics, specific laws, and we have to start with the absolute core. How do we even define health?
Well, historically, it was pretty simple, wasn't it? If you weren't obviously sick, you were considered healthy.
Right, absence of disease.
Yeah, health was just the lack of disease. Medicine was reactive. It was measured by mortality who died and morbidity who was sick. Very basic.
But that definition, it just doesn't cut it anymore. It's changed so much. If you remember one thing from this first part, make it this. The World Health Organization, the WHO, they completely shifted the focus,
They did.
defining health now as a state of complete physical, mental, and social well-being. Complete.
That's a huge shift, a tectonic shift, really. Because it means for us as nurses, we have to focus just as much on health promotion, on prevention, and importantly, the psychosocial side of things, not just fighting off germs. And if you look back historically, well, we kind of earned that shift through tough lessons, didn't we?
Oh, definitely. Think about the late 1800s. Early American cities, they were just battling horrific infant mortality rates.
Yeah.
Smallpox, diphtheria, measles. They were everywhere. And it was largely driven by, crowding, bad water, and, crucially, unsanitary food.
Yeah.
Milk was a huge problem.
A massive problem. And kids were often seen less as patients needing care and more as, well, labor. Commodities, almost.
Grim. So what turned it around?
Public health. That's when the tide really turned. Things we take for granted now, like compulsory smallpox shots for school kids,
Right.
treating the water supply, basic sanitation improvements, and maybe the biggest one, pasteurization, getting safe milk out there in the late 19th, early 20th century.
That must have made a massive difference.
Oh, it crushed the death rates from those communicable diseases. Huge impact.
And this is where the story takes a really interesting turn, right? Because once we started winning the battle against infectious diseases,
Yeah.
the main killer for kids over 1 year old changed completely. It became unintentional injuries, accidents.
Exactly, a total flip. Then you add in the tech advances from the late 20th century, like mechanical ventilation for preemies.
Life-saving, definitely.
Absolutely life-saving, which is amazing. But it also means we now care for many more kids with really complex chronic conditions, things like BPD, bronchopulmonary dysplasia. So we got much better at keeping kids alive, but the whole landscape of pediatric care shifted. We went from mostly managing acute infections to managing long-term chronic disabilities.
And to track how we're doing with these, more modern, complex challenges, the U.S. developed the Healthy People Initiative. We're on Healthy People 2030 now.
Yeah.
And the way it measures success is, well, it's different.
It is. It forces us to look beyond just lifespan. It's about years lived without limitation, quality of life.
How does it do that?
It uses these foundation health measures, kind of in tiers. Tier 1 is about healthy life expectancy, basically, how many years you live free from limitations or disability.
Okay.
Tier 2 looks at the bigger picture, overall mortality, population health, things like activity limitations. It really pushes us towards prevention and focusing on that quality aspect.
So let's look at the hard data then. Mortality and morbidity. We often use infant mortality, that's deaths in the first year, per 1,000 live births as a kind of benchmark for a nation's health, right?
We do. And frankly, the U.S. rate is, well, it's not great compared to other developed nations, often higher, sometimes even double. And it's mainly driven by things like congenital anomalies, babies born too early, or with low birth weight.
And there are significant disparities within those numbers, too.
Oh, absolutely stark disparities.
Right.
Non-Hispanic African-American infants consistently have higher mortality rates. And when you look at older kids, say 1 to 14, where injuries are the top cause of death, American Indian and Alaska Native children have the highest rates of death from unintentional injuries. These numbers really scream for targeted culturally sensitive nursing care.
So that's mortality, the death rates. What about morbidity, the illness side? How do we track that?
Morbidity is trickier to measure consistently, but it's about the prevalence of illness.
Right.
We often look at things like disability, measured by, say, days missed from school. And the data shows almost 4% of kids miss 11 or more school days a year because of injury or illness. That's significant time
What's
lost.
behind that? What's driving this modern morbidity?
A lot of it is socioeconomic, and behavioral factors play a huge role. Poverty is a major predictor. About 18% of U.S. kids live in poverty. Low maternal education, homelessness, these are big risk factors.
And the actual health problems.
Well, the current big threats, sometimes called the new morbidity, include things like obesity, exposure to environmental toxins, drug abuse, and, this is critical, mental health problems.
That seems to be everywhere now.
It's huge. The estimate that maybe 1 in 5 kids has some kind of mental health issue is staggering. It just demands we take a really integrated approach to their care.
Which brings us perfectly to the philosophy, the core beliefs that should guide every single thing we do as pediatric nurses. The 3 pillars, right? Let's unpack those. How do they apply day to day?
Right. This philosophy didn't just appear, it evolved. Think figures like Abraham Jacobi, kind of the father of pediatrics, and Lillian Wald, the public health nursing pioneer. But today, it rests on these 3 pillars. First up, family-centered care, FCC.
Okay, FCC. What does that really mean in practice?
It's not just being nice to parents. It's truly recognizing the family, whoever they define as family, as the constant in that child's life.
Yeah.
They are the primary source of strength and support. It's a partnership.
So, a tangible step for a new nurse. How do you make it real on the unit?
You treat them as experts on their child, because they are. Include them in shift report at the bedside. Ask them, how does Sarah usually react when she's in pain? Adapt routines when possible to fit their family customs. It's not just fluff. Studies show this partnership gets better outcomes and families are more satisfied.
Got it. Partnership. Pillar number 2.
Atraumatic therapeutic care. We know hospitals and procedures can be terrifying for kids and parents too. This pillar is all about doing everything possible to minimize the physical and the psychological distress during any healthcare intervention.
What's a common mistake here? Where do we sometimes fall short?
I think sometimes it's the small things. Unnecessarily separating a child from a parent during a simple procedure, or maybe forgetting comfort measures like a topical anesthetic for a quick poke. Atraumatic care means thinking ahead. How can we reduce anxiety, minimize pain, prevent any physical harm? It's about the environment, the approach, everything.
Making it as stress-free as humanly possible.
Exactly. And the third pillar ties it all together. Evidence-based practice, EBP.
Right, EBP, making sure we're not just doing things because we've always done it that way.
Precisely. EBP means integrating the best current scientific evidence with the child's specific situation, their family's values, and our own clinical expertise. It's what ensures we're aiming for the best possible outcomes based on solid data.
So those are the guiding principles. But the pediatric nurse role itself is pretty multifaceted too, isn't it? Beyond just direct care.
Oh, definitely. Direct care is primary, of course. But you're also a crucial advocate for the child and family, fighting for their rights, getting them resources. You're an educator, tailoring information to the child's developmental level and the family's understanding.
And with more kids having complex chronic issues, that coordinator role seems huge now.
The care coordinator role is absolutely paramount today. Think about a child juggling multiple specialists, school nurses, home care.
There's a lot to manage.
It is. The care coordinator is like the hub, integrating the whole team, ensuring smooth transitions between settings, hospital to home, clinic to school. It's incredibly important for continuity, especially for those kids with complex needs.
And nurses today have to keep learning. Right?
Yeah.
Things are changing so fast.
Constantly. We need to integrate new knowledge about genetics, neurobiology's impact on development, rapid tech advances, and critically, providing culturally focused care. Recognizing that kids today are incredibly diverse and our care plans have to reflect that. One size definitely does not fit all.
Okay, so all these roles, it's complex care. It's all managed using the nursing process, that systematic scientific method.
Exactly. It's our roadmap. It starts always with assessment. Gathering comprehensive data, physical exam, sure, but also family context, community factors, the whole picture.
Then what?
Then nursing diagnosis. This is where you analyze all that data you gathered. You make clinical judgments about the child's health, their developmental status, identify problems or potential problems.
Got it. Assessment, diagnosis, then planning.
Right. outcome identification and planning. You work with the family and child, if appropriate, to set specific, measurable, achievable goals. What do we want to happen? Then you develop the plan to get there.
Then comes the doing part.
Implementation,
Yeah.
performing the interventions in your plan. And this is key in pediatrics. You must adapt everything to the child's age and developmental level. You can't talk to or treat a toddler the same way you would a teenager.
Makes sense. And finally,
Evaluation, it's ongoing. Are we meeting the goals? Is the plan working? You're constantly assessing, reassessing, and adjusting the plan in partnership with the family. It's a continuous loop.
and this whole process, it's held to a certain professional benchmark, right? The standard of care.
Yes. The standard of care is basically the minimum level of acceptable action. What would a reasonably careful or prudent nurse with similar skills and knowledge do in the same situation? That's the standard we're all held to.
And professional groups like the ANA and SPN, they set guidelines for performance too.
They do. They have standards for professional performance that cover ethics, education, using evidence-based practice, quality, advocacy, all guiding how we practice professionally.
Okay, this feels like a good point to shift into that third major area you mentioned,
Yeah,
the ethics and legal stuff. This is where things can get really complex.
they really can. Ethically, pediatric nurses navigate using generally 6 core principles.
We know the big ones. Autonomy, freedom to choose, beneficence, doing good, non-maleficence, avoiding harm. What else guides us?
We also rely heavily on justice acting fairly, treating everyone equitably without discrimination. Veracity, which is truthfulness, and that can be tricky, balancing what to tell a child versus a parent. And fidelity, keeping our promises, being faithful to our commitments to patients and families. These principles help us navigate those tough dilemmas, especially with new technologies creating new ethical questions.
And legally, what's the absolute bedrock rule?
Consent. It's fundamental but critical. Minors, generally anyone under 18, require consent for medical treatment from a parent or legal guardian.
And that phrase, legal guardian, is key, isn't it?
Crucial. Never ever assume the adult who brings the child in is the legal guardian. You must verify that relationship, get documentation if needed.
Okay. And for bigger things, surgery, chemo, even using restraints or involving kids in research, we need informed consent. What's the nurse's specific role there?
The physician or provider obtains the informed consent, meaning they explain the risks, benefits, alternatives. Our job as nurses is vital. We need to verify that the parents actually understand what they're signing. Do they grasp the information? We also make sure the form is filled out correctly, and we often serve as the witness to the signature itself.
But there are exceptions to needing that formal parental consent, right? Emergencies, for example.
Definitely. In a true emergency, if you can't reach the parents despite reasonable efforts and delaying treatment would harm the child, you can provide necessary treatment without formal consent. Sometimes verbal consent over the phone is possible, usually needing 2 witnesses.
What about older kids? Can they ever consent for themselves?
Yes, in certain situations, there's the mature minor doctrine, depending on the state, an adolescent, often around 14 or older, who a physician determines is mature and intelligent enough, might be able to consent to specific types of treatment on their own.
And then there's the emancipated minor.
Right. An emancipated minor is legally recognized as having adult capacity. This usually happens through things like military service, marriage, a specific court order, or sometimes if they're living independently and managing their own finances, they can consent for themselves for all care.
And critically, there's confidential care for sensitive issues.
Yes, this is so important. Most states allow minors to seek confidential care, meaning without parental notification or consent for specific things. Usually this includes pregnancy counseling, contraception, testing and treatment for STIs, substance abuse treatment, and mental health services.
Why is that exception allowed?
Because the reality is, if teens feared their parents would automatically be told, many just wouldn't seek help for these critical, sensitive issues at all. It's a public health necessity, really.
And we also try to involve the child in decisions, even if they can't legally consent. That's assent.
Exactly. Assent is the child's agreement or willingness to participate in a treatment or procedure. It's based on their developmental level, what can they understand. The American Academy of Pediatrics really pushes for seeking assent whenever possible. It respects the child and empowers them as much as possible in their own care.
What if the child says no? That's dissent.
Dissent is when the child disagrees, and it needs to be taken seriously. We have to respect their feelings and try to understand why they're refusing. However, unlike legal consent, dissent usually doesn't carry the same legal weight. It can be overridden by parents or the medical team if the treatment is essential to prevent serious harm or death. but you still have to address the child's concerns.
Okay, shifting to really difficult situations.
Yeah.
End-of-life
Yeah.
decisions.
Here, parents act as the surrogate decision makers. They make decisions about things like advance directives or do not attempt resuscitation orders, DNRs. Some places use A&D, allow natural death orders now too.
And you mentioned the baby doe regulations earlier.
Right, the baby doe regulations add another layer, specifically for infants born with severe disabilities. They essentially set guidelines that can sometimes mandate life-sustaining treatment, even if the parents wish to withhold it, particularly if the decision seems based on the disability itself rather than the medical prognosis. It's complex, ethical, and legal territory.
And wrapping up the legal side, one last absolutely crucial point. Confidentiality and its limits. HIPAA.
HIPAA protects patient privacy and security, of course, but there are critical, legally mandated exceptions, especially in pediatrics.
Mandatory reporting.
Mandatory reporting is number one. As nurses, you are legally required to report any suspicion of child physical or sexual abuse or neglect. No exceptions.
What else overrides confidentiality?
You also generally have to report injuries caused by weapons or criminal acts if a patient poses a serious threat of harm to themselves or others, sometimes called a duty to warn, and certain infectious diseases as required by public health laws. These are non-negotiable duties that override HIPAA's privacy rules.
Wow, okay. That covers a huge amount of ground, but it really feels like the essential scaffolding for pediatric practice.
It really is.
We've gone from the holistic WHO definition of health, traced that historical shift from infection to injury and chronic conditions, and really anchored ourselves in those three pillars: family-centered, atraumatic, and evidence-based care.
Uh-huh.
And then we navigated the nursing process as our guide, and crucially outlined that complex legal and ethical landscape around consent, assent, and confidentiality.
And understanding this whole foundation, how we measure health, the philosophy guiding us, the process we use, and the laws we follow, that's truly what empowers you to provide safe, effective, high-quality care to every single child and family you meet. It's not just theory, it's practical necessity.
Absolutely. So as you go forward, digesting all this, here's something to really think about. We talked about that staggering estimate, maybe 1 in 5 kids facing mental health challenges. Given that reality, how must pediatric nursing actively, consciously integrate psychosocial and behavioral assessment and planning into every step of the nursing process? How will you, in your practice, make sure these often less visible needs are accurately assessed and woven into a truly holistic plan of care for every child?
That's a great question to ponder. Thank you for joining us for this essential deep dive. Now go out there and put this foundational knowledge into practice.